Hi everybody, welcome or welcome back to this channel. This is Shagnik Datta and today we will be discussing about another topic of the cardiovascular system, that is cardiac tumors. We are actually going on with a series where we are discussing the book called as Robbins of Pathology and taking up topics from it and trying to read and understand its lines. So in this video itself, we'll be taking up the topic of cardiac tumors. This in itself is not a huge topic. It's a very small topic which we can easily do. In Robbins itself, it just has got 2 pages dedicated to this topic called cardiac tumors, and we'll be covering the entire bit of that in this video. So without much ado, let's get started. So before we actually get into the lines of Robbins, let us just understand a few things about cardiac tumors. So basically, cardiac tumors are of 2 types, just like any other tumor. That is, they might be primary tumors or they can be secondary tumors. Secondary tumors are basically nothing but tumors originating from other sources, and the most common origins are from the lungs, because lungs is the nearest organ present nearest to the heart. So any tumor or any metastatic component which is present in the lungs may get transferred to the heart, causing a tumor or a metastatic cancer in the heart. The main topic of discussion today shall be the primary tumors. And in case of primary tumors of the cardiac tissue, mostly they are benign as compared to the malignant. And out of benign, we need to study about 2 different tumors, that is myxomas, which is more common in case of adults, and rhabdomyomas, which are more common in case of children. And in case of malignant tumors, these are angiosarcomas, which are common in case of adults, and rhabdomyosarcoma, which are common in case of children. Now let us get into the lines of Robbins. Now, primary cardiac tumors are uncommon. Moreover, most are fortunately benign. The 5 most common tumors have no malignant potential and account for almost 90% of all the primary heart tumors. In descending order of frequency, combined pediatric and adult populations, mind the order, these are myxomas, fibromas, lipomas, papillary fibroelastomas, and the rhabdomyomas. Primary malignant tumors of the heart are exceedingly rare and usually are either an angiosarcoma or a sarcoma with poor differentiation and MT-M2 oncogene amplification. So, the primary malignant tumors of the heart are rare and they are either angiosarcoma or sarcoma, but they are very poorly differentiated and is also associated with MDM2 oncogene amplification. These and other sarcomas of the heart are not clinically or morphologically distinctive from the sarcomas arising in other locations. So basically, the sarcomas present in other organs are morphologically and characteristically similar to these angiosarcomas which arise in case of the cardiac tissues. Now, fibromas and lipomas resemble their counterparts elsewhere. Only the myxomas, papillary fibroelastomas, and the rhabdomyomas merit further mention here. So, we'll be talking about myxomas and rhabdomyomas in detail. Now, myxomas are the most common primary tumor of the adult heart. These are benign neoplasms arising from the primitive multipotent mesenchymal cells. So what are the tissue or cell of origin for myxomas? These are primitive multipotent mesenchymal cells. Mind it. Although the sporadic myxomas do not show consistent genetic alterations, familial syndromes associated with the myxomas have activating mutations in the GNAS1 gene encoding a subunit of the G protein, that is the GS alpha. In association with the McCune-Albright syndrome or null mutations in PRKR1A encoding a regulatory subunit of the cyclic AMP dependent protein kinase. So basically the cyclic AMP dependent protein kinase is being affected due to a mutation in these kinds of genes like GNAS1 gene. Now it is very important for us to understand that these things like the GNAS1 genes and all these hard terms are not really necessary for us to remember. What actually needs us to be remembered is its clinical features and the triads, the symptoms that it shows. So let us get into that. So what are the morphological characters of myxomas? The tumors are usually single but can rarely be multiple. The region of the fossa ovalis in the atrial septum is the favored site. So what is the most common site where these myxomas happen? These are the fossa ovalis in the atrial septums. The myxomas range from small, that is less than 1 centimeter, to large, more than 10 centimeter, and can be sessile or pedunculated lesions. They vary from the globular heart masses mottled with hemorrhage to soft translucent papillary or villous lesions having a gelatinous appearance. The pedunculated form is often sufficiently mobile to move during the systole into the atrioventricular valve opening, causing intermittent obstruction that may be position dependent. Now, histologically, the myxomas are composed of stellate or globular myxoma cells embedded within an abundant acid mucopolysaccharide ground substance. So what is the histological characteristic of these myxomas? These are composed of stellate or globular myxoma cells which are embedded within an abundant acid mucopolysaccharide ground substance. So the ground substance is basically an acid mucopolysaccharide in which a stellate or globular myxoma cells are embedded. Peculiar vessels like or gland-like structures are the characteristic. Hemorrhage and mononuclear inflammation are usually present as well. So what do we need to know about myxomas are, number one, the site of origin. So what is the site of origin? The most common site of origin is the fossa ovalis of the left atrium. So basically the atrias are more vulnerable to myxomas than the ventricles, and out of which the left atrium is more prominent and more vulnerable as compared to the right atrium. Now, what is the most common cell of origin? The cell of origin is the mesenchymal stem cells. Now, what are the different types of myxomas? Number one is the single myxoma, which is the most common type and constitutes about 90% of the cases. And second shall be bilateral, that is both the atrias are being affected, that is 10 to 20% of the total myxomas. Now, these are usually associated with Carney's syndrome, and symptomatically they follow a triad, that is myxomas, skin pigmentations, and endocrine overactivity, and these entire triad is associated with a disease called as myxoma. So whenever there is myxoma, there are associated skin pigmentations, there are associated endocrine overactivity as well. So it becomes a very characteristic finding. Now, let us talk about the clinical features. The major clinical manifestations are due to the valvular ball valve obstruction, embolization, or a syndrome of constitutional symptoms such as fever and malaise. Sometimes fragmentations and systemic embolization calls attention to these lesions. Constitutional symptoms are probably due to the elaboration by some myxomas of the cytokine interleukin 6, a major mediator of the acute phase response. Echocardiography provides the opportunity to identify these masses non-invasively. Surgical removal is usually curative. Rarely, presumably with incomplete excision, the neoplasm can recur months to years later as well. Now, papillary fibroelastomas are curious sea anemone shaped endocardial tumors. They are usually incidental but can embolize and thereby become clinically important. Clonal cytogenetic abnormalities have been reported suggesting that fibroelastomas are benign neoplasms. They resemble the much smaller, usually trivial lamball excrescences that project from the sites of valve apposition. So let us just forget all these heavy terms and summarize the entire thing. So the main clinical feature of the myxoma is due to the valvular ball valve mechanism of obstruction. So the main clinical feature is due to the ball valve mechanism of obstruction. There is release of interleukin 6 which causes weight loss and fever. These are fragile and there might be presence of embolism as well. So these are the most common and most easy to remember clinical features in case of myxomas that we need to remember. Now let us just talk about the microscopic examinations. In case of microscopic examinations of myxoma, what we actually get to see is some spindle cells which are also known as lipidic cells in acidic myxoid matrix. Let us just see an image of it. This is a characteristic myxoid cell. This is a characteristic lipidic cell present in the myxoid matrix. Right? Now, let us just get to the next big topic, that is rhabdomyoma. Now, rhabdomyoma, as we just discussed, it is more common in case of children. Rhabdomyomas are most frequent primary tumor of the pediatric heart. They are commonly discovered in the first years of life during an evaluation for a valve or other flow obstruction. Approximately 1/2 of the cardiac rhabdomyomas are due to sporadic mutations. The other 50% of the cases are associated with tuberous sclerosis, with mutations in the tuberous sclerosis complex TSC1 or the TSC2 tumor suppressor genes. The TSC1 and TSC2 proteins function in a complex that inhibits the activity of the mammalian target of the rapamycin, a kinase that stimulates cell growth and regulates the cell size. So their expression is often absent in case of tuberous sclerosis associated rhabdomyomas, providing a mechanism for myocyte overgrowth. Because rhabdomyomas often regress spontaneously, they may be considered as hematomas rather than true neoplasms. Now let us just get into the morphology of rhabdomyomas. They are gray-white myocardial masses that can be small or up to several centimeters in diameter. They are usually multiple and involve the ventricles preferentially protruding into the lumen. Microscopically, they are composed of bizarre, markedly enlarged myocytes with large collections of glycogen. So this is a characteristic feature in case of rhabdomyomas. That is, they get to have large collections of glycogen in the enlarged myocytes that they possess. Now, routine histologic processing removes the glycogen and artifactually reduces the abundant cytoplasm to thin strands that stretch from the nucleus to the surface membrane, an appearance referred to as the spider cells. We'll just see an image of the spider cell as well. But before that, let us just revise and get and put everything together. Now, what is the most common primary cardiac tumors in children? The benign children, it is the rhabdomyomas. Now, what is its site of origin? The site of origin is the ventricles. Right ventricle and left ventricle are equally susceptible to rhabdomyomas, unlike myomas where the left atrium was more susceptible to as compared to the right atrium. Now, these are associated with TSC1 and TSC2 gene mutations. This is the only information that we need to remember in this case. We don't need to remember the entire functioning of these genes, but we need to remember that these are associated with TSC1 and TSC2 gene mutations. Now, if we talk about the histological feature that we get to see in case of rhabdomyomas, these are characteristic spider cells which contain glycogens. Now these are the characteristic spider cells which have got these tentacles like protrusions from the cells. So with this we come to an end of the topic of discussion about cardiac tumors. This was a very small topic. I hope you like this. If you do, please hit the like button, subscribe to the channel and share this video with anyone who might find it helpful as well. In the next video onwards, we'll continue our discussion about the topic of cardiovascular system. All the best, stay well. Thank you.